Good morning, good afternoon, and good evening to anyone joining us today around the world. My name is Alan Dominguez, and on behalf of the IDDSI, the International Dysphagia Diet Standardization Initiative, I welcome you all to the webinar titled A Regional Food Services Implementation Journey, presented by our panelists, Allie, Stephen, and Stefanie Finch from the Northern Health Authority in British Columbia, Canada. We would like to start by thanking our generous sponsors who allow the work of IDDSI to continue and who support implementation around the world. Now, some quick housekeeping before we begin, and we have some time for other folks to join us. The webinar is being recorded and will be available on our website at the end of next week after the Monday's session. All participants joining us today are in listen-only mode, and this means that the panelists and myself won't be able to hear or see you, and that your microphone and your video will remain off for the session. However, if you have any questions throughout the presentation, you can submit them throughout the webinar and while the presentation is happening. And to do so, you have to use the Q&A button on the middle of your menu bar, and that might be either at the bottom of your screen or at the top of your screen. So you click on that and send us a question, and the panelists will address these questions at the end of their presentation, when we will have about 10 to 15 minutes to do a Q&A period. Now, IDDSI currently doesn't offer continuing education units, but in the upcoming days, a certificate of attendance will be emailed to anyone attending the session via a computer. And as I was saying before, if you're joining us through a phone line, please email us at meetings@iddsi.org to let us know who you are, your name, your phone number, and your email address, so we can email you back the certificate of attendance. Again, we currently do not offer CEUs. Moving on to our presenters for the session. Allie Stephen is a registered dietitian and is the quality improvement dietitian at Northern Health, and she led the implementation team in transitioning the regional dysphagia diet standards to the IDDSI framework. Stefanie Finch, our second panelist of the day, she's also a registered dietitian and is the regional manager of nutrition and food information systems with Northern Health Authority, and she was instrumental in ensuring the IDDSI framework was reflected appropriately within the parameters of a computerized food service system. So, Allie and Stefanie, without further ado, I will hand it over to you to get the presentation started.
Good morning, everyone, or afternoon, evening, depending on where you're calling from. Allie and I would like to thank you for joining us today, and we would also like to thank the IDDSI Global Group for inviting us to speak today about our journey implementing IDDSI in our health region. We recognize that not all that is discussed today will apply to everyone, but hopefully you will be able to pick up a few ideas that will help in your own implementation. So Allie and I will share our journey with you today, including a brief overview of our health authority, our timelines, some of our education materials and strategies used for education. We will also look at the technical implication used in our CBORD system and review our implementation evaluations. We will finish off with our reflections. So hopefully we will leave around 10 minutes at the end of our presentation for some questions. So Northern Health is located in the northern part of the province of British Columbia, Canada. We cover a large landmass of approximately the size of France, serving approximately 300,000 people. So we're big in size, but we're really small in population. So Northern Health has 27 facilities indicated by the red dots on the map. And within those facilities, we are funded for approximately 500 acute care beds and 1,100 long-term care beds. A few years back, Northern Health regionalized our diet office across the health region when we implemented CBORD as our food and nutrition information system. We currently manage all diet changes across the region in an office which is staffed by myself, who is the manager, one menu dietitian, a quality improvement dietitian, which is Allie, and 6 diet technicians. The menu dietitian manages and updates the regional menu, which allows us to standardize products and menu easier. Our quality improvement dietitian works on projects like the implementation of IDDSI. Because we have a centralized diet office and a regional menu, we were able to only have one CBORD database to service all of the food and nutrition information needs. This simplified our implementation. We also have a non-selective menu in our acute care sites, which means that we don't offer choice. I think it's important to point out a few regional implementations which made the implementation a little bit more manageable. We have self-operated kitchens, and therefore we don't have to include a secondary partner like a food service contract company in the planning and implementation process. We also used outsourced textured modified products for our minced and pureed diets. These included pureed meats, pureed vegetables and fruit, minced meats and vegetables, and pre-thickened beverages for milk, juice, and water. So we relied on industry to test and modify their products and meet the IDDSI standards. We have several well-established teams within, which I will mention in more details on the next slide, that acted as site champions and enabled us the information, or ensured that we can share the information out with everyone, and was aware that we were adopting the IDDSI framework. So before we start looking at the process that we took to implement IDDSI, I think it's important to highlight all of the great partnerships already established in Northern Health, which made our implementation attainable. As mentioned in previous slides, we have a regional approach for menu and managing diets. The regional diet office was key to the success of the implementation and led the team in the process. About 5 years ago, Northern Health created a regional dysphagia management team, which funds an SLP, an OT, and a dietitian to provide regional dysphagia support to all long-term care sites in the region. Other teams which were already established included our community of practice groups established by practitioners to provide support to each other, especially for those who practice in small facilities where there are only one that in the area of practice. These included the Dysphagia Community of Practice Group, the Long-Term Care Dietitian Community of Practice Group, and the Northern Health Dietitian Group. These groups were instrumental in providing education at the site. They were also the folks who helped guide us in some of the decision-making we had to make along the way. Allie will talk more to this in her part of the presentation. Our food operators meeting was also a venue for us to use to communicate with the food service departments on education tools available, as well as making the menu and product decisions required for new IDDSI compliant items. Lastly, the BC Nutrition Food Service IDDSI Implementation Group was created by Peter Lamb in January 2019 for all health authorities in British Columbia to help them implement IDDSI and provide support. These partnerships will be discussed further throughout our presentation. I will now hand over the presentation to Allie to discuss our timeline.
Okay, so just before we really get into our timeline, we wanted to show you what exactly our finished product was, and so basically what we've adopted now. You'll notice in the thickened fluid box, we did not adopt level 1, slightly thick, and in the texture modified box, we did not adopt the level 3 blenderized diet. We don't have a significant pediatric population. We do have a pediatric unit at our largest hospital in Prince George, but generally any higher need patients are transferred to the BC Children's Hospital in Vancouver. So we don't see very many, if any really, pediatric patients with thickened fluid diet orders. And then with respect to the blenderized diet, for this implementation, we focused on transitioning existing diets used for dysphagia management, and we didn't really have anything similar that we could work with. So it would have meant introducing a brand new diet level. So we've held off on using the level 3 blenderized diet, but it might be something we look at in the future. You'll notice also that we have a variation of the easy to chew diet, which we've called the easy to chew with minced meat and vegetables. We'll speak to this more as we go through our presentation, but this is something there was a lot of discussion around in terms of how we could keep what was our non-dysphagia minced diet, which we knew clinicians valued, and how we could offer certain items and textures on the easy-to-chew diet within the parameters of our computerized system. And again, we'll come back to that as we move through our presentation here. So these two tables just show what we have in place now, now that we've implemented the IDDSI framework. So how did we get there? This is a brief overview of what our timeline was. We started talking about IDDSI in the spring of 2018. By winter 2019, we were in the thick of educating the region and evaluating our items and recipes, so that in March 2019, we could implement the fluid levels, followed by diets in late May. And then this past summer, we were able to do some reflection on the whole experience and gather some feedback and evaluation. And now we're in what we call our ongoing quality improvement phase. So over the next few slides, I'll go through each of these phases in a little bit more detail. So spring 2018, initial discussions started with some of our key players, particularly through the dysphagia practitioner community of practice. This group is facilitated and supported by Northern Health's Regional Dysphagia Management Team, or the RDMT. So this felt like a pretty intuitive place, really, to start talking about IDDSI. Those initial conversations focused on what adopting IDDSI would mean for our current diets, how the terminology would change, how diet compliances, or what's offered on each diet, how those would change, and just overall what our plan would be. What we heard from our dysphagia practitioners was that keeping a structure similar to what we were already using would be preferable. So the table on this slide here shows what our texture modified diets looked like before we adopted IDDSI. And something to note is that in Northern Health, we follow the Vancouver Coastal Diet Rating Guidelines. So whether it's therapeutic diets or texture modified diets, we use these guidelines for coding our items and recipes as either compliant or non-compliant to all of our diets. So this structure was established through the use of those diet rating guidelines. So we had our regular diet, a finger foods diet, and a dental soft diet. Then we split into two tiers. We had a dysphagia tier and a non-dysphagia tier that used similar terminology, but with the understanding that there were differences in what items were offered on each diet. So for example, on the dysphagia cut-up diet on the left, we offered buttered breads, and on the non-dysphagia cut-up on the right, we served non-buttered toast and rolls and other bread products. So keeping this system was preferred for a couple of reasons. One, it was familiar to staff, so it would be helpful in kind of easing into the transition. It was a little bit less radical. And two, there would be the opportunity to continue offering items like bread products to those who could tolerate them safely, but just had some other needs around textures or particle size. So the idea was that we would maintain the system for naming convention, but replace the terms cut up and minced with soft and bite size and minced and moist, respectively. So for example, our dysphagia cut up would become dysphagia soft and bite size, and our cut up diet would become just soft and bite size. So this was our initial approach, but if you're keeping track, you'll notice that this isn't quite the same as what we ended up doing. And the other piece that came out of these conversations was the implementation date. So we estimated we need about a year based on the IDDSI implementation calendar. So we decided that we would first go live with fluids in March 2019 and follow with the diets later in the spring in May. So just for some more context, in Northern Health, because we are quite a large region with communities spread widely apart, community of practice and regional group meetings are generally done over the phone, with the exception of once or sometimes twice a year, where groups often come together for a couple of days and hold face-to-face meetings, similar to a mini conference. So in the fall of 2018, we had some great opportunities to connect with both the Northern Health Dietitian Group as well as the Support Services Council through their face-to-face meetings. And at both these meetings, the Regional Diet Office IDDSI team presented to the groups, introducing IDDSI, sharing a bit about what we were planning and when it was going to happen. We did want to make sure everyone knew we need their help in terms of passing on information and education, getting their teams familiar with IDDSI. And for the clinicians, particularly those in long-term care, we also wanted to give them ample time to assess their residents from an IDDSI perspective. So we gave them some instructions on how to document in the residents' CBORD diet file which of the new IDDSI diets would be appropriate for the residents when the time came to switch. And then we also took the opportunity to get some feedback from them around what education strategies would be most effective, who else at their site would be important to connect with, and just get a sense of what we might come up against, both helpful and challenging. So with this feedback, we really got into education planning and developing resources to help everyone visualize what this transition would look like. And I'll show the resources we made and speak to them in just a little bit, so stay tuned. In December, we started taking a deeper look at our products and prioritizing what we needed to look into for alternatives, the highest priority being bread. We didn't want to completely remove the salad sandwiches that we offered to dysphagia diets, so we started trialing a pureed bread product that is on our menu now for those diets. So we're offering the salad filling with the pureed bread, and presentation of that depends on the site. In late December, we also sent out what we called IDDSI starter kits. So we sent those to each site's food service department, and those were packages of some of the key resources we wanted to make sure each site had. We communicated to our food service operators through our bi-weekly food service operators meeting that these were coming, what they could do with them, and made some suggestions for what could be shared with. Oh, sorry. Right. Then in January, the health authorities in British Columbia were brought together in a provincial working group to talk about and support each other in IDDSI implementation. So there were really great conversations that started to happen around using the framework terminology as clearly as possible. Many of the health authorities present either followed the Vancouver Coastal Diet Writing Guidelines like we do, or were a part of writing and developing them. So the discussion started happening here around plans for the diet writing guidelines to be revised and updated to include the IDDSI framework. So from our perspective, we were already moving ahead and had implementation dates planned. But now that we knew the diet writing guidelines would be getting reviewed, we definitely wanted to make sure that what we were planning on doing could align with what the diet writing guidelines would eventually be. And then the second point on this slide just mentions that we started to code food items and recipes into Seaboard, and Stefanie will speak to what that means when we get into technical implications. February was a heavy month for education and connecting with everyone about what the upcoming changes would really look like. We were a month away from implementing the fluid levels, so we held a webinar over Skype and invited anyone and everyone who might have something to do with diet. So care staff, nursing, food services, dietitians, and of course any remaining dysphagia practitioners. We really got a good turnout, notably from people outside of those we connected with on a regular basis. You'll see this when we go through some of our evaluation slides, but these webinars were fairly well received, and the feedback was that it was helpful to have them recorded and has slides available to use afterwards. And then you'll see here also that we recorded a separate session that discussed only the fluid. It was geared towards food services in that we went through the in-house thickening a little bit more. There are a few products that we thicken in-house. And it was really just the immediate need to know for the upcoming fluid transition. Because it was shorter than the live sessions, it was just easier for management to use during staff huddles and meetings. And then before we knew it, it was March. And so on March 4th, we transitioned our fluid levels over. We adopted levels 2, 3, and 4 for our beverages, which replaced the nectar, honey, and pudding terminology, respectively. March and April was a really significant time for us beyond implementing the fluid levels because our provincial group was really getting into the swing of things, and there was great discussion happening about diet levels and naming conventions and the direction in which the diet rating guidelines would move. And through these discussions, it became pretty clear that what we were proposing for Northern Health, that two-tier system, didn't quite fit the bigger picture, which might have jumped out to some of you already. So March and April, we made the decision to collapse our 2 tiers and also use the newly introduced SKU level. So then, of course, we had to make sure we updated everyone on that change and updated the resources that we already put out. And so this should look familiar. This is what our final transition looks like. Oops, sorry. This is what our final transition looked like. We kept our cut up and finger food diets, but moved them to be under the regular diet umbrella. Our dental soft diet moved to the easy to chew diet. Our mince diet became easy to chew with minced meat and vegetables. And then our dysphagia diets transitioned as we had originally planned for. So the dysphagia cut up became dysphagia soft and bite-sized. Dysphagia minced became dysphagia minced and moist. And then our dysphagia pureed just remained as dysphagia pureed. And something that I do want to be clear about is that this table shows only the changes to naming conventions, right? So there were, of course, changes made to what was offered on certain diets, particularly our dysphagia diet. And that's what we addressed through that ongoing process of item and recipe coding. I also want to speak a little bit more to the easy to chew with mincemeat and vegetable diet because it's not explicitly in the framework. When we were reevaluating our 2-tier plan, the question was asked, why have a regular minced or a non-dysphagia minced diet? Like, what's its value? So we went to our dysphagia practitioners and our long-term care dietitians, and what we heard was that the non-dysphagia minced diet was quite valuable for some fairly common scenarios. For example, a resident does well on a dental soft or a cut-up diet, but certain items are more difficult to get through. So it was helpful to have a minced diet to kind of bridge the gap between that dental soft or cut up and pureed. And so having this diet helped avoid mealtime fatigue and help maintain intake. And I mean, that's just one example, but what we were hearing from our clinicians was that losing the non-dysphagia minced diet would have a significant impact on patients and residents. So somehow we needed to offer some minced items somewhere within the IDDSI framework other than just the minced and moist level or level 5. And from our perspective in the diet office, where we maintain Northern Health diets and CBORD, we were going to have some challenges when making minced items available on non-minced diets, just because of how we use CBORD. We knew that there would be some risk of folks on any non-minced diet getting minced items, showing on their meal ticket unnecessarily and unintentionally. So we felt that to make things as seamless as possible in our system, We needed to have a separate diet in which we could code minced chicken, for example, as compliant, and whole or cut up chicken breast as non-compliant. And it really came down to the meat and vegetable items when we looked into where the value of that non-dysphagia minced diet was. So what we offer in place now is an easy to chew diet where the meats and vegetables are minced, and we call it easy to chew with minced meat and vegetables. Okay, so moving along into May, we were into the final countdown. So we were set to go live on the 27th of May. And leading up to that date, we were finishing up coding our items and recipes. We were checking in with everyone to help sort out any remaining questions or concerns. And then on May 26th, Stefanie, myself, and our colleague Darcy were in Seaboard making changes that Stefanie will speak to in a few minutes. So on May 27th, we were live. We were using the IDDSI framework. So that wraps up kind of the overview of our year-long process. And what I want to share with you now are some of the education tools that I mentioned as we went through that timeline. We did our best to avoid reinventing the wheel, so we absolutely used some of the resources developed by IDDSI, in particular the What is IDDSI poster and IDDSI flow test posters. Those we included in the starter pack that got distributed in December 2018. And then when the consumer handouts were published, we made those available to practitioners as well, just through our printing center. Those consumer handouts were resources that early on we'd heard from practitioners that they'd like to have, so we were really excited to see IDDSI publish those. We did need to develop some of our own resources just to illustrate how our Northern Health specific diets would be changing and to give everyone at all our sites a really clear picture of what they could expect. So that involved some posters and visuals, but also the webinar and some online training modules. On the left here is what we called the Northern Health Transition Poster. And when we go through the evaluation results, you'll see that this was the tool that seemed to be most helpful. It's a condensed version of the What is IDDSI poster, and then it shows the mapping table we were looking at earlier. Then on the right is another visual tool we made. This idea came from one of our dietitians, and it was made with busy physicians in mind. So it was intended to go on the online physician team site to give them the need to know information. But some of our sites found use for hard copies as well, and they got put up in elevators and other high traffic areas. And then we had the webinar I spoke about earlier. And the webinar was geared towards what everyone would see in terms of changes and differences between old and new diets. It covered information about what IDDSI is and why we were adopting it, but its major purpose was to show how diets would be changing in more detail that could be shared on a poster, while also allowing some time for questions. So it was recorded and made available for anyone to view and share with their teams, as were the slides. So we distributed those to anyone who was looking for some supporting tools in education they were doing on site. On this slide in the top left, there's a screenshot of our Provincial Learning Hub platform. And this is where we house the online modules that were created. There are 3 modules. The first is an intro to IDDSI, then there's a module about fluid levels and a module about food levels. The intention was for these modules to be used as an initial education tool, but more so as something that could be incorporated into ongoing and future training for new staff to the organization. And in the bottom right is a version of the image that was displayed on all Northern Health computers as the desktop background. We had a version of this image showing the week prior to each go live date, as well as post implementation. This image was displayed just to draw attention to resources for anyone who felt they needed some more information. So those were the major education tools we used, of course, in addition to forums like the Community of Practice meetings. Okay, so before I start with what we did in Seaboard to implement IDDSI, I thought it would be helpful to provide how our Seaboard system is set up. So as previously mentioned, our health authority regionalized the food and nutrition information into one database and created a regional diet office which processes all diet information for patients and residents. One thing to note is that we do not have a diet order interface with a clinical program used in our health authority. This made the changes of diet names in our Seaboard system easier that if we had had an interface and we had a clinical system to change as well. Our regional diet office also handles all the printing for the region using Automate. This allows us to hold print jobs until we were done and all of the changes in the database, and then reactivate the print jobs once the once the information had been updated in the Seaboard system. Our team of dietitians were also responsible for evaluating items and compliances for all new guidelines, facilitating item testing and education on the day of implementation. So 6 months prior to our go live, we started looking at how we were going to implement IDDSI in our computerized environment. We'll first touch a bit on the fluid transition, which happened in March. We already were using the nectar, honey, and pudding thickness in our health authority. So when we transitioned to mild, moderate, and extreme thickness, all we had to do was rename our current diets and change the names of the recipes so that their current names appeared on tray tickets and tallied. For our solid transition, we started by creating an inactive diet for all our new IDDSI diets and use those diets to start coding. When we use the Seabourn report, then we use the Seabourn report called an item compliancy crosstab report, which allows us to use or to see what was compliant and what was not compliant in our old diets. And that's indicated on the screen. We went through all of the items and recipes and determined if the items were compliant or not, and with the new IDDSI diet. When the item was not obvious, we marked it as non-compliant, and then the item or recipe went on our testing list. Once we tested the item, if it passed the IDDSI test for the diet, then we went back into the Seaboard system and changed the compliance. So we erred on the side of caution and kept the items non-compliant until everything was tested. Once we were done coding, we started tray ticket testing for all new IDDSI diets using our inactive diets. This allowed us to see what was appearing on the tray tickets and enabled us to pinpoint where we needed to work on for variety. So one example that we found was our macaroni and cheese was no longer compliant on our soft and bite-sized diet. Our current noodle did not meet the 1.5 centimeter cube rule for soft and bite-sized. We explored different options with plasticizers and found a small baby shell, which was 1.5 centimeters once cooked. This is how our macaroni and cheese became creamy baby shell pasta. Other items we sourced out was the pureed bread. Pre-IDDSI, we were serving mint sandwiches on our dysphagia cut-up diet. When moving with the IDDSI framework, that diet lost the variety of sandwiches. So we sourced out a pureed bread, which we are now using to serve dysphagia soft and bite-sized sandwiches to improve variety. Something else we noticed when tray ticket testing was the lack of variety for vegetables for the dysphagia soft and bite-sized diet. They were getting diced carrots a lot because that was our background vegetable in our system. It's compliant with so many different diets. We then had to look at our vegetable background rotation and ensure that we were getting a bit of variety in their day so that people were not getting carrots every day.
Looking for new products to improve the variety of these diets is an ongoing process with the goal of improving selections in these diets. Another thing we did was create new preference groups to help practitioners provide diets that were geared for residents and patients. Creating these preferences and utilizing existing preference groups like no mix consistencies allowed clinicians to remove problematic items while still allowing a more liberalized diet. When we use, the day before our go live day was when we all the changes were made in our Seaboard system. We started making our changes after all the days printing had been done and before the next day's printing began. We did hold a few jobs to ensure that we had enough time to make the changes in the system. Our first step was to rename the old diets with the new names, and then we copied the compliances we had set up in our inactive diets to the newly renamed diets. This saved us time on the switchover day as we had minimal coding left to do in the system. We also had one diet which we completely removed, our regular puree. This diet was really similar to our dysphagia puree and didn't seem a need for it anymore. So we Z'd that diet. So we put Z's in the front to identify it when we went through the patient list with notes. We printed the patient list with notes, including the clinical notes, which was where the clinicians were putting what new IDDSI diets they wanted their patients and residents to be on. We printed these sheets for all of our facilities, and then we updated the system with specified diet when the specified diet didn't match what the clinician wanted. We also updated preference groups per the clinician's request. Once all the changes were done, we reactivated our print jobs in our automated systems so that the print jobs were sent to the sites. The first thing we did in the morning was send out a communication to all our stakeholders about the success of our switchover. We then had the diet technicians do a double check on all diet changes for accuracy. When the old diet terminology was used in an order for a dysphagia diet, the diet technicians also provided on-the-spot training by calling the facility and speaking with the person who ordered the old diet to let them know of the new diet terminology. We were actually really surprised at how few calls we had to make since our go live day. Our office has also been providing ongoing support for the sites regarding the transition. I will now hand over the presentation to Allie for her to review our evaluation.
Okay, so as I mentioned earlier, this summer we were able to dedicate some time to getting feedback on how implementation went from everyone else's perspective. We kept using our community of practice meetings to elicit some of that feedback and provide space for our colleagues to ask questions, share challenges or concerns, and just generally let us know of anything that might need to be adjusted. We also sent out a survey to as many groups as possible and asked that they share it further with anyone else on their teams who has anything to do with patient and resident diets or meal times. We really wanted as many perspectives as possible so that we could get a sense of how information flowed, what worked and what didn't work. So grand total was 43 responses. We would have liked to hear from more people, of course, but we're thinking there may have been a few contributing factors. Summer holidays for one, but we also know that some of the frontline staff we were looking to hear from might not be accessing their emails regularly or might not be able to sit down with a paper copy and submit. So things like that we're conscious of looking at our evaluation results. But we were very appreciative of everyone who did take our survey. And so what I'll do now is go through a few, not all, but a few of the questions that we feel might be most relevant or helpful. The first question we asked was what the respondent's role was. And as we can see on this chart here, we heard from quite a few working in food services. Management at the top includes kitchen supervisors, coordinators, and managers. Food service staff listed second there, includes any food service workers and cooks. We had the same amount of dietitians respond as food service workers, but then we also got a fairly good response from people we didn't connect with directly ourselves, like nursing staff, recreation and care staff, and then also a few individuals in facility management and educator roles. The questions captured on this slide were meant to give us some information on how prepared sites were for dysphagia management diets to change. So on the left side, we asked the simple question, did you know our diets were changing before it happened? And we see that 81% of those 43 who responded said yes, they did know. So majority of responders were not surprised, which was great to see. Although we do recognize there might be some non-response bias at play. Of course, if you said they did not know or they weren't sure. We wanted to build off that question by asking, now that we've changed, do you know about the changes? And so shown on the left, we see that almost 75% of people said they knew about each of the diets, and within that group, well, half of the total responders indicated they also know where each of the diets fit into the IDDSI framework. And then we can see about a fifth of responders know about some of the diets, 5% know there's been a change, but don't really know what those changes are. And finally, down in the bottom right corner, we see that no one said they didn't know they had changed. So thinking about the people who didn't know that diets were going to be changing before it happened on the left, it seems that once we did transition, there was some recognition of those changes and perhaps some further education done or sought out. Continuing to build off those questions, we then wanted to know if the perception of changes made to our diet, if that was associated with IDDSI. So we asked, what is your level of understanding of IDDSI? And just clarified that by understanding, we meant an awareness of what IDDSI is and why we adopted it. So as you can see here, most people who responded either have a good or excellent understanding of IDDSI. And I mean, this was a fairly rudimentary evaluation process, but it seems like from the perspective of people who took our survey, the changes they saw to diets were linked to the concept of IDDSI. And then the last piece we wanted to share from our survey was around the education tools. So we asked respondents to let us know which education tools or resources they found most helpful. And that was through just a free text box. So responses were tabulated by number of mentions, since some people mentioned more than one resource in their answer. So on this chart, the results are shown as % of total mentions. And so I alluded to this earlier, that the transition poster that had the mapping chart on it seems to have been the most useful. And further comments around this just indicated that the value really lay in having a resource that could be posted anywhere and showed that transition, the plan really clearly. The webinar came in, well, as a not so close second to the transition poster, but again, comments on the webinar were that it was really helpful to have it recorded and available later on. And then the online modules and discussion and conversation tied for third. We did ask for anything that would have been helpful that was not available, as well as just some general comments. There were a few comments that it would have been helpful to have more information about what exactly would be on each diet. And while I think that might have been a bit tricky to facilitate, since, I mean, it was an ongoing process for us in terms of figuring out what each diet would look like. The suggestion was made that a 3-day sample menu be provided, which I think could have been feasible a couple weeks leading up to the transition. In some cases, more in-person education would have been helpful. It did seem that this feedback came more so from nursing team members or those whose on-site presence was a bit more unpredictable, just with shift rotations or days of work, that sort of thing. So that's just something to consider, whether it's you providing education or if you're supporting others in educating, just considering how you might reach as many of those rotating team members as you can. Of course, I mean, sometimes there's only so much you can do. One of our survey respondents was on maternity leave and then came back after implementation happened. And it sounds like she did really well in figuring things out and using some resources, but I think that just illustrates that it can be difficult and sometimes it's not possible to get to absolutely everyone ahead of time. And then general comments that came up fairly often were that there was plenty of time for site champions to connect with their sites and provide education and build familiarity, and that there were plenty of resources available to help facilitate that education at the site level. So that just sums up some of the most common feedback that we got. Now, just to wrap up, we wanted to share some of the overarching reflections we've made. And something to keep in mind is that these are certainly not the only challenges we came up against, but we wanted to pull out some themes that we felt would be most relevant to this larger audience. So in terms of challenges, as we mentioned, our implementation was led through the regional diet office, which again meant that we couldn't be at all sites helping facilitate education and training, nor would that be effective really. We just felt that wouldn't necessarily add value traveling around to the region, because we'd only be able to get to connect with a handful of people who are there on that day, on that time. So again, we really relied on our site champions. And I will say that I mean, we've listed this point as a challenge, but at the same time, our key player groups were so wonderful to work with. So even though we couldn't really tell firsthand how things were being received at the site level, we were never really concerned just because of how engaged our site champions and players were. So I think that just speaks to that team building aspect. And the second point here is about setting up the framework in a black and white system. We know that the IDDSI documents provide some clear guidelines on foods allowed, foods to avoid, which were really helpful in our coding process. But there is also, of course, some language around referring to the clinician's assessment for inclusion of certain items like bread. And we always want to be providing patient and resident-centered care. So we knew it wasn't really going to be an option to box in practitioners, I guess, in terms of what diets they could order and what the implications would be in terms of what would be allowed and not allowed, so to speak. So the challenge was in offering flexibility in Seaboard, where they're basically a set of rules that the system follows in order to build a meal ticket. And so I think the easy to chew with mincemeat and vegetable diet is probably the best example. And then finally, something we're continuing to work on is the variety of menu options available to our dysphagia diets. We found that the level 5 and level 6 diets have become more restrictive than we'd like. So we're continuing to seek out some recipes and products that would improve the menu for folks with diet orders. What worked well for us? Stefanie spoke to how some of the pieces of our context helped us along, but we did want to just revisit two major areas that we felt were instrumental. So first was involving as many different groups as we could. That goes back to that earlier challenge of not being on site anywhere, right? I mean, there's no way that this implementation would have happened effectively without using the strength our region has, which fundamentally is people, and I think that's no different wherever you are. So if anyone from Northern Health is listening, know that we're so appreciative of you. And second, we were happy with the decision to stagger our implementation dates for fluids and foods. Transitioning fluids over a few months ahead of the diet just acted as a soft launch and kind of ease into it a bit and get used to the IDDSI terminology. And then moving over to the lessons learned column, we've captured a few, again, overarching lessons learned, but really I think these were more so things that we were constantly reminded of throughout the process. And the first was to be adaptable. Obviously, our plans for how we were going to implement the framework evolved and got a bit of a facelift fairly close to our go live date. We definitely could have dug our heels in and said, nope, we're going with the 2 tiers, but that's not really in the spirit of IDDSI. So it was really important that we kind of buckle down and make the updates we needed to make to keep moving forward. Seek out different perspectives. This ties into connecting with all our key player groups as regularly as possible, but also valuing the perspectives that came from our provincial working group. As a group, we knew that health authorities differ in many ways that would impact implementation, but getting input from fresh eyes can really lessen the risk that you might overlook something because you've been so immersed in it. And lastly, be transparent with progress and keep communicating. I'd say even at the risk of almost tiring people out with your message, just keep sharing. I think it's better than under communicating and having people not know what's going on and not allow that opportunity for input. I don't think it matters if you're an independent facility or a whole region like we are. There are a lot of considerations. You don't want to miss out on those other perspectives. I think too, if progress and decisions and challenges you're experiencing are kept to yourself, that puts the perception out there that you know exactly what you're doing. And maybe you do, but more likely you don't. And I think it's important to be transparent about that so that you can build those relationships or strengthen existing relationships that will help see your implementation through successfully. And so that concludes the part of our session where we talk at you. So we've left a bit of time for questions, but we did want to let everyone know that you're more than welcome to get in touch with either of us if there's anything that we didn't cover today or that you're wondering about, or if your question doesn't get answered. So our contact info is on the slide there. And thank you for joining us.
Thank you, Allie, and thank you, Stefanie, so much for that very comprehensive process of implementing IDDSI. So as you mentioned, we have a few minutes to answer some Q&A. So we already have a few in the queue. Thank you for sharing your email addresses as well. I received an inquiry about a specific product, so they can get in touch with you directly. So let's just get to the questions. Could you give a rough estimate of the amount of time spent per week on implementing?
Yeah, so this is Allie. So implementation was definitely a large part of my role for the last year. As a group, we met well, once formally weekly, but given that we're in the same office, and by we I mean Stefanie and myself and your colleague Darcy, you know, there was a lot of chatter and informal conversation and work being done on it. So I mean, it was, again, like I said, it was a large part of my role, and so I would say, I mean, probably half of my time was spent on IDDSI, but there were, I would say as a group, probably probably 3 to 4 hours a week in team meetings and in those coding sessions and things like that.
Great. Thank you. What are some examples of breakfasts and dessert items that are allowed or modified for the IDDSI diets that you use?
So we currently outsource a lot of our products. We use there's a bread pudding that we use from Appetito that we use on our breakfast menu for the purees and the mince, and we've actually now included it on our soft and bite as well. So we've kind of, in the past, wouldn't have had it on their diets, but now we do. But if you want to email us, we can email you some of our menu items that we use off this presentation.
Great, thank you. So you just touched on bread. So someone else is asking if the level 7 with the minced meat and veg allow for regular bread.
Yes, it does.
Okay, great, thank you. We have another question here, and they're saying that the main challenge in updating the recipes that are used across, there's a challenge in updating recipes that are used across multiple facilities. So can you discuss how you guys approached updating the instructions in your recipes to make sure that they were IDDSI compliant?
Yeah, so as Stefanie covered, our menu is regional, which means that our recipes are regional as well. So all of our facilities follow the same recipes. So Darcy did some work in just making sure that for the soft and bite-sized and minced diets, in those recipes, we were specifying the particle size. So actually for the soft and bite-sized, the particle size was no different than our previous cut-up diet and dysphagia cut-up diet. So those recipes we found we didn't need to update quite as much as the minced and moist recipes, just because that size specification was already in there. But so those updates came out of our office, so and were distributed for the facilities to use as they normally would.
Great, thank you. Did you have site champions or implementation champions on every site?
Yeah, so I would say that the groups that kind of made up the heaviest, I guess, proportion of our site champions were our dietitian group and our food service operators. So even at sites where, so some of our sites are too small to have their own dysphagia practitioner, which is where the regional dysphagia management team comes in and provides some more support. So in cases where sites either don't have a dietitian or a dysphagia practitioner, the food service manager or supervisor was instrumental in being a site champion. Mm-hmm. And in sites that had both, they worked together quite nicely.
Great, thank you. Allie and Stefanie, do you mind going back to your contact information slide? I have a couple people asking for that, if that's okay with you.
Yeah, absolutely.
Thank you, thank you. There we go. I have a couple questions about patient reception to the changes, and in particular the pureed bread product.
Sorry, I'm not sure we can answer that completely because we're not on the site, but we have heard back from some of the food operators to let us know that it's become a very popular product. But we haven't surveyed the residents to see their acceptance.
Right. No, that's fair. It'll happen eventually. Did you or were you able to consult with CBORD at all throughout the process for their recommendations?
Sorry, for what accommodation?
Recommendations from CBORD.
You know what, we haven't. We just got creative with how we have our system set up. However,
saying that we had a meeting with CBORD last week, and they asked us how we implemented, and we shared our strategies, and they were agreeing that that was a good strategy. So that's probably the extent of communication we've had with CBORD.
That's great. And you know what, if I can just add to that, your presentation is the perfect example of how you've taken all those IDDSI resources that are available for the public, and you've made them your own, and you figured out a process that worked for your facilities. And I think that's what we encourage everyone really around the world to do. And presentations like this one are so important, so that folks around the world and around the country can see how it can work when you make it your own, and when you have champions that are really pushing forward the process of implementation. So thank you for that. I'm sure there's a bunch of folks who are attending this webinar who found that inspiring. So thank you. I'm going to go through 4 more questions real quick, and then I'll do a sign off. So do you have any sample menus that you could show, or that you'd be willing to share? You don't have to share them right now.
We are more than happy to share our sample menus. We can send them to you, or how would you like us to share?
I think it'd be better if they contact you directly. That's okay.
That's a great idea. So if you're interested in having some of our resources, please email us directly and we will provide.
Great, thank you, Rebecca Holmes. That was the direct answer to your question. How has IDDSI created additional costs for food prep? Like, was it more expensive to go through all this food prep?
You know what, I don't think we can really put a number on it. I don't think it has in actual fact, because we haven't really changed a lot of our products. We are looking at different products now to increase variety for sure. You know, for example, the purees, there's a few companies out there that are creating some really nice pureed cakes and desserts. We're doing some trials on those. Right now we're serving a lot of pureed fruit, so we want to give them a bit of option. That will probably increase our cost, because I'm sure the cakes are a little bit more expensive than the fruit. As for the pureed bread, maybe a little higher cost than, say, a slice of bread, but I don't think it's that significant. And it does offer a lot of variety to the residents.
Mm-hmm. How did you involve IMIT and electronic documentation changes needed for reports and resources?
So because we don't have an interface with our diet order entry with our clinical system, we didn't have to include them.
Okay.
And we have our own IT group that works with CBORD, but I do most of the coding in CBORD, so it was me.
I will add to that as well. We didn't really touch on this in the presentation, but we did have to touch base with anyone who owned any like order sets, things like that. So we did make updates to like diet admission packages and things like that. And that was just a process of connecting with the right people and letting them know what would be changing and what would be more appropriate to include on those kinds of documents.
Great. Last question of the day: how do you handle ice cream?
Oh, we use the magic cup. So we don't serve ice cream on our thickened dysphasias. However, we use a product called Magic Cup, and it keeps its consistency cold or at room temperature.
Great, fantastic. Okay, so that marks the end of our Q&A period. Thank you, Allie and Stefanie, for sharing again this presentation. That marks the end of this webinar. A quick reminder that a recording will be available on our website and on our YouTube channel at the end of next week once the second session has happened. As well, certificates of attendance will be emailed once that second session is done. If you know of anyone who would benefit from or would be interested in the contents of this webinar or these webinars, please share the recordings with them, or we still have another session on Monday, so you can share the registration information via our website. And lastly, we've announced another webinar, an IDDSI town hall, so you can get all your questions answered directly by the board of directors, who are the folks who did the original research and created the IDDSI framework. Allie and Stefanie, I thank you so very much again for being here with us today and for sharing this very informative presentation. I would like to thank the listeners for joining us today. If you're joining us still on a phone line, please make sure to email meetings@iddsi.org to let us know who you are, so we can make sure that you receive your certificate of attendance. Thank you. We hope you found this information useful in your practice and that this inspires you to go forward with implementation. We are signing off. Have a great rest of your week, and until next time, thank you.
Thank you.